at a recent echo, Dr. Zulfikar recommended that we, instead of looking at CT images as frozen, that we see if we could scroll through CT images. So we're going to try that for the first time today. We're counting on you to help us look at these CT images. And so it is possible to stop as we scroll through. And we have, I'm sorry, I forget the correct radiologic terms. We have frontal views and we have cross-sectional views. And when we get to it, whoever wants to describe those with the accurate radiologic terms, please do so. So in some ways, we don't have necessarily dramatic CT findings, but we're learning how to use scrolling in this echo to look at those images. So this patient is a 67-year-old man, came to Cabin Creek Health Center in late 2018, early 2019. He mainly came for benefits counseling, help with his black lung benefits, but he was offered pulmonary rehabilitation and he accepted that. He started pulmonary rehabilitation, I think sometime in early 2019. He graduated in June of 2019. And looking at his record at Cabin Creek, we haven't really heard from him since because his pulmonary care provider was not within Cabin Creek Health Center, but elsewhere in the community. Going back up to the top, Caitlin, well, actually, you're right. Let's go to his history. So a 67-year-old retired miner. He had over 30 years underground coal mining exposure. His pulmonary diagnosis based on the testing that we did was restrictive lung disease, is restrictive lung disease. He did not have obstruction on his spirometry, as you will see. He had comorbidities of GERD, hypertension, coronary arteriosclerosis. His PFT showed mild restriction and both on the spirometry and also on his lung volumes. He had a baseline 6-minute walk test of 1,080 feet, and his dyspnea level was 1. So he didn't have severe dyspnea. And for those of you who don't kind of deal with this clinical stuff all the time, 6-minute walk test is really an important functional test that we use in pulmonary rehab, and I think the pulmonologists invented it. It's very simple. You have people see how far people can walk for 6 minutes. Those of us who are in pretty good physical condition should probably be able to do about 2,000 feet or a little bit more in 6 minutes. It's very common for us to see 6-minute walk tests of 350 or 500 in people with severe lung disease on oxygen. We even have people come to pulmonary rehab who can't even walk for 6 minutes without stopping. So that's a really important test that we use a lot. It's a real index for us of function and severity. One thing that we've started doing is using what we call a chronic lung disease profile. So on the screen you see CLD profile. And this is kind of like a thumbnail that we use in all of our progress notes as people go through pulmonary rehab to keep an overview of what this person's situation is. And without making it a lot longer, if people out there notice something you think that we're missing, which is really important, I'd be interested to hear that in the discussion. So our chronic lung disease profile consists of who's the primary care provider, and going through the Cabin Creek record, I couldn't figure that out, so I had to leave it blank. What are their pulmonary diagnoses? In his case, it was co-workers pneumoconiosis, restrictive lung disease. What's their tobacco status? And unfortunately, even though he has coronary artery disease and lung disease, he still was smoking at least a half pack a day. And we're sad that during pulmonary rehab, we weren't able to persuade him, support him to stop. It's interesting that as I look at this record, we have a contradiction between the dyspnea level up above, which says 1, and the dyspnea level here, which says 3. I think that we could either split the difference, or 1 is probably more likely. So that's an error. We'll get to his spirometry in a second, except that on this, On our echo case presentation form, we only have spirometry and DLCO. He had complete PFTs, and so on spirometry, mild restriction, not obstruction. Total lung capacity 71, which is mild reduction, and his DLCO was 67, which classifies as mild, but to me, any reduction in DLCO is pretty significant. You can see the numbers there. His FVC, he's 77% of predicted. His FEV1, he's 83% of predicted, and his ratio was 79%. And whether you go by the ATS criteria, using lower limits of normal, or the gold criteria using less than 0.7, 70%, he did not have obstruction. We do not have post-bronchodilator values, I don't believe, on him. So a couple things on this before, and so we're going to show you some imaging. But before we go to that, one thing I want to mention is somewhere in his history there's a diagnosis of bronchiectasis. And in a second, I'm going to show you two ILO X-ray forms. This is, again, for people who don't look at this stuff all the time. Generally, when we do a chest X-ray, we get back a narrative report from the radiologist that describes what she or he sees. With black lung, there's a special X-ray that we do. It's called it's a little bit more exposure, I think. And any one of the pulmonologists, you can correct me on that if you want, or elaborate on that. But there's a special X-ray and a special method for reading it. It's called a B reading. And when you do it, when the radiologist, and you don't have to be a radiologist to be a B reader.
Hey, Dan?
When the person interpreting does this B reading, they fill out a special scoring sheet. That's what you're going to see in just a second. And as they go through it, they're mainly looking for changes of pneumoconiosis. But if they see other things, they make a note of that. And actually, Dr. Werntz has a special role with NIOSH in terms of making a note of other things. Like
hey, Dan?
Yeah.
Just real quickly, it's a single view PA X-ray, so pulmonary anterior, but it's a normal X-ray. There's nothing special about the X-ray, but it does get a special interpretation once it's done.
Great, thank you. So in a minute, in a couple seconds, we're going to show you two scoring sheets, or two of these B reader sheets, not the whole sheet, but the bottom, and read what the radiologist said she saw. So one of them was done in 2019, and one of them was done in 2020. And Dr. Werntz, you actually did do a DOL exam on this patient. I think it was in January 2019. I don't expect you to remember that. Because we keep everything de-identified in these echoes, I can't tell you his initials or anything. But I don't think it's necessary for this. So yeah, let's look at this first one. So this one was done, this is the bottom of this B reader scoring sheet. And what it says is irregular, approximately 8 millimeter opacity adjacent to right second ribs. CT or comparison to previous is recommended to exclude malignancy. And then it says sternal wires. So he got this in January 2019, and I'm fairly certain this is his. There's another one that I found in his chart that I think is also his, which was done about a year later. This one's, and it actually was done just last week, says diagnostic findings of simple and complicated pneumoconiosis, obscured aortic something compared to previous or chest CT. So it's very common. And I must confess, I'm less confident that this belongs to him, but I think I found it in his record. So I'm showing both of them. So now we're going to look at his CT scans, and I'm going to put it to, and what I think we'll do is we'll go through both of these once. Don't start yet, Caitlin. We'll go through both of these once, and then we'll go back and do them again. And when we do them again, I'm going to ask the three of you, Dr. Stansbury, Dr. Sela, and Dr. Wernz, to kind of among yourselves narrate. And if there's a point where you want us to stop, just say so. And a couple things. We have a possibility of complicated pneumoconiosis. We have concern about malignancy in the right upper lung, somewhere near the second rib, 8 millimeters. That seems like that'll be hard to see. And we have a mention of bronchiectasis. And also, I'm looking for sternal wires. So before we start, anything any of you three want to say to Caitlin or how we should look at this scrolling data? Okay, well then roll it. By the way, Caitlin can zoom this. Why don't we make it as big as we can, unless our experts think we're losing resolution by doing that. Try to get it where it's as big as possible, but small enough to be in focus. This looks a little blurry to me.
I don't think I have more than 2 options for this.
Okay, well then let's stick with this. Unless they want to try it different.
Okay. Should I go to the next one?
Oh, it seems like there's more.
Yeah, it's just replaying itself.
Oh, okay. Can you zoom this and do it with our Zoom view, please?
Hold on.
It's interesting. We should get all the way to the diaphragm and the even the dome of the liver on this, but I'm not seeing it. Well, let's go ahead and look at the other one, the frontal view. What was that view called, you guys?
Axial.
Axial?
Yes.
Okay, thanks. And this one?
Coronal.
Coronal.
Thanks. Axial coronal. Okay.
Did he have a previous injury?
Not that I know of.
His left hemidiaphragm is really high.
This is Krista at Cabin Creek. So from what I can recall with this patient, when he had open heart back in 2012, apparently he had an ice pack during the recovery, and that it had basically frostbit his lung tissue.
Well, usually what happens there after cabbage is, that cardioplegia causes frostbite injury to the phrenic nerve. That's very common, and you get hemidiaphragm paralysis. I think that might be what's going on with him.
Yeah, that's what I can recall.
I mean, it looks like he does have an area of consolidation or scar tissue in the posterior part of the right lung, kind of up high. And that could, I mean, I don't know when this x-ray is or when this CAT scan is in his time course, but that could be with the Yeah, that stuff.
See if you can stop it.
Can you stop it?
Stop
Yeah.
at about 4 seconds.
Right there?
No, 4
A little
seconds.
further.
Oh, I'm sorry. 4 seconds from the end. Sorry.
No worries.
There.
So that fuzzy thing that's kind of escaping off out towards the outside of his right upper lung. I mean, that could be, it looks like it's scar tissue from something. I don't know if that's PMF or if that's something else.
Yeah, it certainly could be PMF. The thing always makes me nervous is in PMF, though, is you should see unilateral disease. This is right upper lobe isolate, it's just on the right. Usually you have sort of symmetric distribution, so you should see a little bit on the left, which I don't see. What if you had a bad pneumonia at any point or something?
So, specialists, if this is all you had and you just had to go by it, what would be the radiologic diagnoses? I'm realizing that these are not completely accurate, but just what would you call here?
I would call that, there's definitely some fibrosis and scarring and just a regular opacity, with maybe some ground glass. But as a radiologist, I would say that needed followed up. Is that what they saw on the chest x-ray, or do we not really know?
Well, she was talking about an 8 millimeter thing at the second rib, so I don't think this is that.
Unless it's grown.
Yeah.
And lung cancer is most commonly in the right upper lobe. Doesn't look like a classic sort of malignancy to me, but sometimes adenocarcinoma can surprise you. That's kind of a different.
Sorry, Rob. One thing actually we have a PET scan that was negative for malignancy. We don't have the images, but that is.
Oh, okay. That makes me feel better. It's always tough doing those PET scans because, PMF lesions can light up on the PET too. That makes me feel, but that's probably old scar then. But that is not what's causing his dyspnea. He does have a little bit of bronchiectasis too, but I think it's that left hemidiaphragm elevation and non-functioning diaphragm. It's probably driving his dyspnea.
Where's the bronchiectasis? I was wondering about that.
So you probably need to scroll down a little bit or scroll through a little bit more. It wasn't extremely impressive, but it was there. Are you guys familiar with the signet ring sign? It's usually better on axial views. So so if you look at where the left
Sorry, just tell me where to stop.
there's a little stop. It was probably at about 5 seconds from the end.
Whoa, you did do it. You can drag back. Good.
Trying to find it.
There.
Maybe a little bit more. 1 second forward. You can kind of see it there. I mean, it's not terribly impressive, but stop. You see right above the left hemidiaphragm, there's something that looks like an engagement ring where you have the blood vessel just above. Yeah, right there. It looks like an engagement ring or signet ring where you have the airway that's bigger than the blood vessel, and it looks like an engagement ring.
The white blob is the gem on the ring. It's as big as the ring.
Yeah, exactly. Yeah, and then below that's the airway where you put your finger.
Huh.
called the signet ring sign. It's that hole with the blood vessel just right above, a little bit to the right with your arrow. A little bit to the right. Oh, you just passed it. But a little bit to the left. Down, down. Right there, yeah. See that? How it looks like a wedding band or an engagement ring?
Put the tip on the black hole, Caitlin. Yeah.
Yep, right. Perfect.
Oh.
It's called a signet ring sign. But it's definitely not that impressive. You know, it's there, but I don't know that it's playing much of a role in anything other than, you know, may give you some more secretions and sputum production, but
anything else that that any of you three or anybody else wants to comment about this, these images? Going forward, well,
just so I've said this from the negative perspective, there's no widely accepted system for looking for simple black lung on a CT scan. So you really can't see that as well on a CT scan as you can on an X-ray.
Looking for what, Carl?
For simple black lung, for the small opacities. The PMF or the large opacities you can see on a CAT scan quite well. But the small opacities, there's no grading system like there is on a regular X-ray for looking for small opacities in a CAT scan.
So I have a question for the group, and again, especially for our specialists, about well, first of all, I think in general on these chronic lung disease cases that we present, to me, really the optimal should be to have the chest X-ray picture, which we missed out on here, and to have the CT scans if they're available. And so to me, that should be what we shoot for every time. But what do you all think of this quality of CT scrolling imaging? If we have the CT disc, is this what we want? Is there a way to do it better than this that we should be shooting for? Like I thought you could see that I was just holding my iPhone in front of the computer screen to get these images, and so it wasn't steady. So one thing would be to put the phone on a tripod when you shoot this, but is there any way that with available technology that we can and should do this better?
I mean, I think that works fairly well for, you know, our purposes. You know, one thing we could do is, you know, the state has that Synapse radiology program now where, you know, it's a kind of far-reaching database where you can upload any image and log in and look at the image that way. I don't know how easy that would be. I know we have a lot of hospitals in the area, when they send us a patient, they load all the imaging on that. The only issue I might see, and there's probably a way to de-identify it, but you know, the patient's information is up there when you log into Synapse. But I thought for our purposes that did work fairly well.
Okay. Well, we'll keep trying to do that. Somebody who isn't with us today is Chris Updegraff, who's a respiratory therapist at Preston Memorial, together with Dr. Sela and Stacy Stewart, and he's doing some work on his own time with Partners in Health, and I'm hoping that he might help us sort of build up more of an inventory of these cases. But so we're going to keep working to have the chronic lung disease, to have more, so Caitlin and Mitra aren't scrambling every month or every 2 weeks to know whether they have a case or not. And also to try to help the respiratory therapists out at the sites become more sort of fluent and comfortable with this case reporting system and getting these images in. But Caitlin and Mitra are really great about organizing what we send them. One thing to be careful of, one recommendation I have is if you're going to submit a case, submit the case first, and then they put a echo case number on it, and then submit images that have the case number on the images. That way it'll help them keep track of the images while preserving the de-identification. Okay, unless any other comments about this. Oh, one question I had for the group was, do you think this person was a good candidate for pulmonary rehab? Why or why not?
I guess it wasn't clear how limited and how much dyspnea he was having. It didn't seem like he was very limited to me, right?
That he was not?
Yeah, did he?
Yeah,
did he have much fun?
His gold group was, his gold grade and group was 1A, meaning no obstruction or little or no obstruction and no exacerbations or hospitalizations. But Brenda's here and she's got a comment.
Oh, I thought he was a good candidate for pulmonary rehab because one thing, he's still smoking. He lives in a small community within the Dalles area. And so him able to get out and maybe get other resources for his health might not be so available. And I think maybe look more at what's going on with his PCP and who that is. And then he might be one, like you said, that doesn't have much motivation, or maybe he doesn't have a great support system. You don't know. So I don't know. I just thought maybe those couple things might. I'm not sure.
What diagnosis would you use to qualify him?
Right. And one thing is, in order to get it paid for, you have to have certain numbers that qualify the patient based on their insurance type. So you're right.
This is Brandy Bell at Lincoln Primary. I think maybe seeing just pre and post measures would probably validate how much the pulmonary rehab helped him with just looking at the CAT questionnaire and the Dartmouth questionnaire. Maybe we could see with those that, you know, just symptom-wise, he's improved over the 4 or 5 months he was in the pulmonary rehab program. I'm with Brenda. You know, sometimes just bringing patients in because they have a mild restrictive lung disease, it creates that, you know, exercise twice a week, socializing, being around other patients that share the same community as them and disease process as them. Sometimes it's just motivating for those patients. They're not as severe to need pulmonary rehab. I definitely don't think we're ever wasting time with any of these patients.
Well, like I said, I agree with that. I just don't know how you would get it approved.
What?
How to get it approved? We don't have to get it
Approved with Medicare.
Well, that gets into the whole payment, payment thing, which is pretty complicated. But with standard Medicare, you don't have to get it approved if they meet the criteria on obstruction. But there's also, but you also can submit it without prior authorization with standard Medicare. With some of the Medicare Advantage payers, you do need prior authorization. But you can submit it and get paid on a diagnosis of restrictive lung disease. It doesn't have to be COPD. And with Department of Labor, speak up, those of you who deal with it. As long as, like say with somebody with federal black lung benefits, as long as they have a diagnosis of pneumoconiosis that's affecting their quality of life and their function, that gets paid for without prior authorization. If it's Department of Labor, when you have commercial payers that are managing the federal black lung benefits, then some of them require prior authorization, like HealthSmart,
AIG.
AIG.
Smart.
So the whole billing thing is a whole topic in itself, but generally we can get it paid for.
Okay.
Well, before we run out of time, and because we promised to talk about the Catch My Breath curriculum, let's go ahead and jump to that. So we're going to switch over to our didactic, Caitlin. And Holly, remember, I'm sure I'll do most of the talking, but this is your topic too.
Right.
Okay, I'm going to get these pictures. So we wanted to talk to you about the primary prevention of COPD means tobacco-free kids. Next. And as many of you know, our goal statement with the Appalachian Pulmonary Health Project, number one, is to work for the primary prevention of COPD. And also, as a number of you commented when you checked in, including at least Brandy Bell and Tara Miller, there would be no Appalachian Pulmonary Health Project if there was not a Grace Andorni Pulmonary Rehabilitation Centers. This whole thing for us started with Grace Andorni Pulmonary Rehabilitation Centers, and we did add to the model working on primary prevention. But our other goals are completely the goals that we were given as Grace Andorni Pulmonary Rehabilitation Centers. Next. So tobacco use is the leading cause of preventable disease in the United States. Nearly all tobacco product use begins during youth and young adulthood. If we want to prevent COPD, the way to do it is prevent, as best we can, prevent first use. Next. And I'm going to let you quickly scan that with your eyes. One thing here that you might not know, and it's important to know for us, is that COPD is more rural than urban. And we don't know why that is. I always think it should be the other way around because there's air pollution in urban areas. But the prevalence of COPD is almost double that in rural areas than urban areas. And the difference is getting worse instead of better. Next.
Working people.
1 in 4 high school students are using e-cigarettes in the United States as of 2020, and that keeps going up. Next. Here's a graphic of the prevalence of cigarette use. Okay, so this is not e-cigarettes, cigarette use. But interestingly, cigarette use had been going down, 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 down due to really great prevention efforts in all the states around the country. Next slide. The use of cigarettes this says by grade. Okay, so these curves are 8th grade, 10th grade, and 12th grade. 12th grade is at the top. If you look, in 1976, over 25% of high school seniors were smoking. And with a lot of great prevention work, both public health and educational, that went down, down, down until in 2016, under 5%, it was like 3.6% of 12th graders were smoking. And then Juul hit. Next slide. And so you can see there was a low point in use of any tobacco product by students, and you can see there's separate curves for high school students and middle school students, so that in 2017 it was about 6% for middle school students, and it was about 20% for high school students. One of the problems in looking at this data is that they show you different things. So this is any tobacco product, and the slide before was smoking, what they call combustible tobacco. So I'm sorry that's a little confusing, but the point is that of this slide is that usage had gone down, 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 and was going down, and then it started spiking up, both for high school and middle school in 2017. Next slide. this shows figures for the United States. The slide after this is going to show you West Virginia compared to the United States. But what you see here are the years 2017, 2018, 2019. Here you see all three of the measures: any tobacco use, e-cigarette use, and smoking use. And let's first look on the left side. Any tobacco, you can see it for middle school students going from 5.6 to 12.5% between 2017 and 2019. Smoking stayed level, around 2%, but e-cigarettes went from 3.3% to 10.5%. This is a tribute to the power of marketing in the 21st century. Juul and the other companies should definitely win an award, and their advertising agencies should definitely win an award. They had their shareholders owe them a tremendous debt of gratitude for this wonderful work, because they tripled the use of e-cigarettes in middle school kids. And over on the high school side, you can see that it went from e-cigarettes went from 11.7% to 27.5% last year. Smoking actually kept on going down. So that's the picture for the United States. And so you've all been hearing about this. It's been in the media all year, this horrible epidemic of juuling and e-cigarette use among middle school and high school students. Here are the numbers for the country, and now here are the numbers for West Virginia. Next. So I made this little table up last night, just comparing 2017 and 2019 in the United States. If we look at high school, last year in 2019, and this data comes from the National Youth Tobacco Survey, which is done each year, I believe, by the CDC. So in 2019 in the US, as you just saw, e-cigarette use 27%, in West Virginia 35%, and in a few minutes I'm going to show you a study that 2 high school students in Boone County did of all their high school fellow students. They found that 53% of seniors in high school were using e-cigarettes, and they said the rate was even higher among athletes. Over on the middle school side, you can see in West Virginia, it went almost tripled from 5.9% to 15.3%. So we've had this terrible increase in the United States from 3.3 to 4.9 in middle schools. West Virginia, it's way, way worse. And that kind of validates what we hear from the students themselves and from the school nurses and from the principals and from the teachers. So how to respond? Next slide. One response that's occurred nationally is development by the University of Texas Houston Health Science Center of a curriculum called Catch My Breath. And actually one of the adolescent health coordinators in our area named Kim Major, who actually works for New River Health, and her job as the adolescent health coordinator and health educator, found this curriculum, told us about it, we looked at it, it seemed like it was perfect for the problem, and this was 2 years ago when middle school was at 5% in West Virginia. Now it's 15%. So we started using this last year, got a grant to use this from the Palatine Foundation, and Holly Mitchell's project actually is to work to bring this to 4 counties especially that are targeted. Holly, your cue is in a second. Next slide. So Holly, would you like to say a little bit about what you're doing before we show this 2-minute video, or do you want to show the video and then comment?
Well, we can kind of frame the video now. We are at a couple schools already. Last fall, we have East Bank Middle, Herbert Hoover High School that we have some active sessions. And then currently we're in an implementation phase with some of the other counties and their schools. And we're looking at, we call this the B5, 10. So we're trying to get up like 5th and 10th graders, that grade A range. And we're actively pursuing, all the grades that we can get into. And we want to get, because it's a 2-year grant, but we're looking at 2,400 kids, but certainly that's not the limit. And we have the teams, which are the health teachers, an administrator at the school, and then our FQHC site person that comes there. These schools are aligned with these clinics that already have a clinic involved with the school, and these teams carry out the sessions. And I kind of adopted East Bank Middle as like a site that I can kind of go to kind of keep the pulse on things. And going back there on Thursday, but they deliver the sessions in a class that's already kind of grouped together, health class, biology class, and homeroom, something like that. But it's at the health class at East Bank Middle. It's at about 4 sessions for a successful, implementation of the program. And we're trying to get as many students as we can throughout the program. And then, if we get a couple students that had the program before, it's not a big deal, but we're trying to get students through the program, throughout the 2 years at these schools.
Okay, great. Let's go ahead and look at that top one. Yeah. That might be the one that didn't have the audio. We'll see.
This is a great overview of the program too.
Catch My Breath is an e-cigarette and Juul prevention program developed by the University of Texas Health Science Center at Houston School of Public Health and disseminated by Catch Global Foundation. The program is best practices based and meets national academic standards, Common Core standards, and many state standards for health education. Catch My Breath has 5th, 6th, 7th, 8th, and 9th through 12th grade tracks. Schools may choose to teach the program in any grade or multiple grades, as each track is standalone. Thanks to funding from CVS Health, Catch My Breath is free to schools across the country. When schools enroll in the program, they receive access to all program materials through the Catch.org platform. The online platform allows the Catch team to keep all program materials up to date with the latest vaping products and science, as well as notify users when new resources become available. Catch My Breath consists of 4 lessons that each take 35 to 40 minutes. It's recommended that schools teach 1 lesson per week over the course of 4 weeks. The lessons are a combination of teacher presentations and peer-facilitated small group discussions and projects. Students will assess health hazards and dangers of e-cigarettes and Juuls, analyze personal influences and industry marketing tactics, and learn and demonstrate refusal skills. The program includes detailed teaching instructions, scripts, and PowerPoint slides. Minimal teacher planning is involved or needed. The curriculum can be taught in a variety of subjects including science, health, physical education, and advisory or homeroom. There's also a PE supplement that incorporates calisthenics and other physical activities alongside the core educational components and objectives. Before teaching the program, teachers are asked to watch an online training video. The video gives teachers a basic understanding of e-cigarettes and orients them to the program lessons and content. Schools are asked to participate in pre- and post-program teacher and student surveys. To learn more and enroll in the program, visit catchmybreath.org.
Back to you, Holly.
Well, a lot of the teachers that we talked to about doing the program as we're moving towards the implementation process, they are welcoming this because unfortunately, the funding for the tobacco cessation has been cut, and they are looking for something else because the problem with vaping is so high in these schools, and they are welcoming this because they're having disciplinary problems and they're trying to figure out how to curb this. And even with law enforcement involved, I've talked to a few other schools that they're really excited about getting a part of this, and so we're excited too. We feel like it's going to be a wonderful thing to kind of branch out to other parts of the state as well. So
Great. Back to the PowerPoint, please, Caitlin. And while we're going back to that, I just want to reemphasize for people that you can go to catch.org, and then when you get there, you have to, Catch is a whole big wellness program. You have to click on e-cigarettes or vaping to get to the website for this. Next slide. At the beginning of that video, they said that it's best practices based. As of this week, we have wonderful news. It's now evidence-based because the developers of this program just published a controlled study of the Catch My Breath program in Public Health Reports. I'll show you that in a second. In our last, I know we've got 4 minutes here, Caitlin. So this shows that the Catch My Breath program has been delivered in 49 states, 1,100 schools to over 326,000 students so far. So they're all over the country. Next. This is about program impact, and this slide was developed before they published the report that I'm about to show you. But their model is that the average 7th grade class is 192 students. If we do nothing, 17 of them will try e-cigarettes. Now we're talking about 7th grade. It would be much higher if we were looking at 10th grade. But of 192 students in 7th grade average, 17 will try e-cigarettes if we do nothing. 8 would be prevented from doing that with Catch My Breath. And the reason we know that, they know that, is because on the pre and post student surveys, one of the questions for the students is to say, what's your intention about using e-cigarettes or vaping? Nationally, 152,000 fewer 7th graders would try e-cigarettes if all schools, all students had this course. Next slide. So just this week in Public Health Reports, we finally got a controlled study of Catch My Breath. And if you jump to the conclusion, ever e-cigarette use, in other words, have you ever used an e-cigarette? Ever e-cigarette use was lower among middle schools. The study was done, unit of analysis was school, not student, because they, like we, keep the student's identity anonymous. We do not, so they did this by looking at school use overall. What they did was they did 12 middle schools in Central Texas, 6 were control, 6 were intervention. E-cigarette use was significantly lower among middle schools that implemented the program than among those who did not. And then they say that this needs to be replicated in group randomized longitudinal study design with longer follow-up. They followed up, they did data at baseline, 4 months, and 16 months. Next slide. Here's my summary of what they found. And at 16-month follow-up, 45% fewer students in intervention schools than in the control schools reported ever using e-cigarettes. There's a lot more to say about this study, what they found and what they didn't find, and I've just barely had a chance to look at it myself. The graphic on the left shows you the usage at baseline, 4 months, and 16 months. On the left side is the control, on the right side is the intervention. It's really worth looking at more. Next slide. Another really important development this month is that the Commissioner of Health, Catherine Slemp for West Virginia, published a report on West Virginia youth and vaping, a dangerous combination. These were her summary report and recommendations. Pretty much the statistics here are the ones that I cited to you earlier about usage in the United States and West Virginia. Another exciting thing that happened was the American Lung Association came out with their 18th annual report on tobacco prevention in the United States. They found that West Virginia was using less than 7% of the money recommended by the CDC for tobacco prevention. I'm sad to say that this is another area where, at least at the state legislature level, there simply is not an awareness of the need to fund this. And next slide. And now I wanted to show you, to close, a newspaper article. I think it's from the Huntington Herald-Dispatch or from Charleston Gazette, about what 2 Boone High School seniors did about this themselves. So this is January 24th, Huntington Herald-Dispatch, and just inch down a little bit. So this is, so Scott High School and Sherman High School are 2 of the 3 high schools in Boone County. So you have Kelsey Akers on the left and Haley Saravallo on the right, Boone High School students who did a project to poll for the use of e-cigarettes in their among their Boone County High School fellow students and classmates. Now, most of the text of this picture is worth 1,000 words. So they're talking to the committee, the House Committee, or it's a legislative committee on prevention and treatment of substance abuse at the legislature on January 23rd. Most of the text of the article repeats all the statistics you've already heard. So just gradually go through, Caitlin, until we get to the bottom where it talks about what they did. Okay, there we go. Some schools, so we've already heard 16% in West Virginia high school students. And then they say some schools are seeing even higher usage. These 2 students presented to the House Committee on Prevention and Treatment of Substance Abuse. The 2 surveyed all the high school students in Boone County's 3 high schools and found 53% of the student body used vapes. The number was even higher among student athletes. Scroll down. It's huge in our school. We see it every day. We know it's not good. Chemicals are bad. Kids are getting under their desk and smoking it. Teacher doesn't even know. Keep going. And then there's something really interesting. Saravallo says, quote, everybody does it, unquote. That's typically what you hear from the students, even the student leaders. It's wrong, and it's one of the myths that the Catch My Breath is trying to dispel, because a big part of their pedagogy and messaging is based on social cognitive theory. And the myth that everybody does it makes it the norm. And one of the things they're trying to point out is that it is not the norm. Most kids don't vape. So that concludes this presentation. If you would like to know more about Catch My Breath or how to get it in your kid's school in West Virginia, you can get hold of me or Holly.
I just posted my contact information in the chat. So thanks, Dan.
Thank you all so much. We're at 9:01. I don't want to keep people from patience. So if you do have questions or anything, please email them and we'll make sure they get everywhere they need to. Everybody have a wonderful day. Our next session is on the 17th, and I have Dr. Stansbury scheduled to give the didactic. All right. Thank you all, and thank you, Dr. Doyle, for the case and the presentation.
Thank you. Have a good day, everybody.
You too. Met and talked to Holly.
You too.
Well, we were at a meeting.